there were various trials in various countries like US, Australia. So they enrolled various patients. So one was Process, one was Arise, one was Promise in UK. So they showed us the primary outcomes. So no statistically significant difference was found in primary or secondary outcomes in any of these trials. P-value was insignificant. Now, we all know capillary refill time. We all have studied it, how to see capillary refill time and how it tells you about the perfusion. So capillary refill time targeted fluid resuscitation was not superior to lactate targeted one. This was shown in a study which was published in Annals of Intensive Care. But it was associated with comparable effects on regional and microcirculatory parameters and hypoxia surrogates. So wherever you do not have the facility of measuring lactates, you can guide your fluid therapy with capillary refill time. So stopping fluids in patients with capillary refill time of less than or equal to 3 seconds appeared safe in terms of tissue perfusion. So wherever you are not getting a lactate level, you can just see the capillary refill time. If it is less than 3 seconds, it means you have achieved your tissue perfusion and you can go down on your fluids and other blood products if you are giving them. Now, second was mean arterial pressure. In patients with septic shock who are on vasopressors, a targeted mean arterial blood pressure of 65 or higher MAP targets was recommended. This is a very strong recommendation because they also showed that in patients who have chronic hypertension, even maintaining more than this MAP, that is around 75, 80, helps in improving the mortality. So this was a study published in New England Journal of Medicine, which compared high versus low blood pressure target in patients with septic shock. So they wanted to determine if a MAP of 80 to 85 was better or if a MAP of 65 to 70 was better. So patients who had chronic hypertension, there they targeted a MAP of 80 to 85. And they came to the conclusion that incidence of doubling of blood creatinine level and the rate of renal replacement therapy both decreased in patients in whom of hypertension whom mean arterial pressure was kept at 80 to 85 and not at 60 to 70. Although there was no group difference in overall rate of adverse events, but in patients who had in whom high blood pressures were kept, they were at more risk for atrial fibrillation. Maybe because they had high support of vasopressors, which led to more cardiac irritability. So now sepsis per se usually is because of infection. Although diagnosis of infection is very important because only then you will be able to define or identify which antibiotics are to be given, which organisms are suspected, which organ is affected, where is the source of infection. So continuous evaluation and searching for the alternate diagnosis and discontinuing empiric antibiotics is necessary. Now, time to antibiotics. For adults, it is recommended that antibiotics should be given within first hour of the recognition of the sepsis. You should not delay the administration of antibiotic for the want of blood cultures. It is recommended that as soon as you draw the blood cultures, you should give the first dose of antibiotic within first. But if for any reason the blood cultures are not available, you are not able to collect the cultures, do not delay the antibiotic. Just give it. It is a very strong recommendation. For adults with possible sepsis but not in shock, they recommended that rapid assessment of the infectious versus non-infectious causes should be done, and patient should be given within 3 years. It should be the decision should be made whether it is an infective cause or a non-infective cause. So in patients who have possible sepsis without shock, antimicrobials should be given within first 3 hours. For adults who have low likelihood of infection and there is no shock, antibiotics should be deferred while continue to closely monitor the patient. So in patients who are in sepsis, give antibiotic within the first hour. In patients who have sepsis but not in shock, within the first 3 hours. In patients who are having less likelihood of sepsis, they are not in shock, do not give antibiotics. So this is just a diagram so that you can understand better. If sepsis is definite or probable, administer antibiotics immediately, ideally within first hour. If sepsis is possible, administer antibiotics immediately, ideally within first hour, or you can rapidly assess the patient if shock is not there and administer it within first 3 hours. Now we already saw that in our case, I mentioned the patient's procalcitonin was 90. So we all know procalcitonin is a hormone which is released from our body. So how does it help? So procalcitonin, it is a diagnostic marker for sepsis. So this was a meta-analysis which was published, which showed that procalcitonin is a helpful biomarker for early diagnosis of sepsis in critically ill patients. But the results have to be interpreted carefully. Why? Because procalcitonin is released in our body in various other conditions also, which may not be sepsis. So how do we use procalcitonin to reduce patients' exposure to antibiotics in intensive care units? This was pro-rata trial, which concluded that a procalcitonin guided strategy to treat the suspected bacterial infections in non-surgical patients in ICU can reduce antibiotic exposure and selective pressure with no apparent adverse outcomes. So it is useful in de-escalation of the antibiotics. Now, as I told you, procalcitonin can be high in patients who may not have sepsis. Why? Because in there are various conditions, because procalcitonin is a natural hormone which is released in the body. So there are some physiological conditions also, and there are some pathological conditions also in which this hormone can be increased. It is physiological in newborns during initial phase, so you cannot label them as having sepsis. Patients who have ARDS, even in non-infective causes, it can be high. In tropical illness like malaria, in systemic fungal infections, it may be high. In severe trauma, following major surgeries, severe burns or heat stroke, in patients who have pneumonitis, or in patients who have calcitonin-producing tumors like medullary thyroid carcinoma, carcinoid tumors, small cell carcinoma of the lung with paraneoplastic hormone production. In patients with cytokine storm, that is especially after administration of monoclonal or polyclonal anti-thymocyte globulin, that is ATG, in treatment of rejections, or in patients who are being treated with familial Mediterranean fever. Now these were the condition in which the procalcitonin was high. So there are some conditions in which procalcitonin, even if there is an infection, it may not be raised. So what are those conditions? So in very early course during an infection, the procalcitonin level may be normal. Or if the infection is not widespread, it has not yet gone into the bloodstream, it may be just localized. Or in patients who have subacute bacterial endocarditis. So what are the biomarkers to start antibiotics? So biomarkers, there are no biomarkers. Procalcitonin is just used for the de-escalation of antibiotics. Should not be used to start an antibiotic. You have to start an antibiotic depending upon the clinical status, your physical examination, your level of certainty, whether the patient is suffering from sepsis. There are various, like I told you, SIRS criteria, Q-SOFA score, along with procalcitonin. Procalcitonin alone should not be the criteria to start to start an antibiotic or an antifungal. Now, we have already covered the diagnosis, the criteria. So now you need to give your patient within the first 1 hour, if the patient is in sepsis or shock, your antimicrobial. So what will be your antimicrobial choice? Now your antimicrobial choice depend upon if there is a high patient who is at high risk for MRSA infection, that is methicillin resistant staph aureus, then you use empirical antibiotics which cover the staph organism, that is MRSA coverage is there. In patients who has low risk of MRSA, you should be not using antibiotics with MRSA coverage. You should be only using empirical antibiotics which do not have MRSA coverage.